Today for the third in the Governor's Opioid Response Seminar Series. My name is Elaine O'Connor. I am the Medical Director of the Maine Maternal Opioid Misuse Initiative from the state level, so I'm helping to expand access to services for pregnant women with substance use disorders. I also have the privilege of co-chairing Gordon Smith's Maine Clinical Opioid Advisory Committee, so play a couple different roles at the state and then as well as at some other healthcare settings. Although a few items of housekeeping. First of all, we have no disclosures and that the views presented today do not necessarily represent the views of the Governor's Office or GHHS. If you would like to get continuing education credits, please complete the evaluation forms and return those. We're expecting about a 40-minute presentation today and then about 10 minutes for moderated questions and answers. You cannot actually unmute, so if you have questions, please put them in the chat and then they will be answered. I will be following the chat box and we will answer them and share the answers as well. Also in the chat, you'll find the handouts that are there if you'd like to download those, and as well as the link to AdCare for future conferences in this series. The only other event that I want folks to be aware of is that the next in the Governor's Opioid Response Seminar Series is on Friday, December 4th. It will be a topic about prevention of substance use disorders. So I'm delighted to be here today. The presentation that we're going to hear today is called The Workflow, Preparing Primary Care Sites to Integrate Medication-Assisted Treatment. I think this is a critical issue as we're trying to expand access across the state. This is the common challenge that primary care practices feel in terms of starting this work. So we're really delighted to be here today and listen and learn about the ways in which they've done it successfully here. I'm pleased to introduce the two presenters. First, we have Jessie Higgins, who's the Director of the Integrated Behavioral Health at Northern Light Acadia Hospital in Bangor. An Acadia provider since 2010, Jessie has practiced consultative psychiatry in a family medicine practice at Eastern Maine Medical Center since 2011. She developed and directs a program of integration that leverages licensed clinical social workers and psychiatric mental health nurse practitioners on-site and via telehealth in outpatient medical practices throughout the state of Maine. The mission of this program is to improve access to behavioral health expertise for outpatient medical practice patients, families, providers, and staff. Jessie has participated as a clinical leader in Maine Quality Account's Patient-Provider Partnership, Medication Decisions in Behavioral Health, Maine Chronic Pain Collaborative, and Capacity Building for Compassionate Tapering Pilots. She is a national speaker on topics that include integrated behavioral health, shared decision-making, and strengthening medical practices as a trauma-informed access point for patients presenting with mental illness and substance use disorders. Jessie continues to pursue excellence in integrated care as an active member of several hospital and community committees, in which she advocates for policies that embody and promote compassionate and collaborative whole patient care. Jessie holds a Master of Science in Nursing and a Graduate Certificate in Health Policy and Management from the University of Southern Maine, and earned a Postgraduate Certificate in Primary Care and Integrated Behavioral Health from UMass Medical School. She is a volunteer member of the Maine Frontline Warm Line, an on-call touchpoint for first responders and medical personnel. In her spare time, which is hard to believe she has any with this bio, she enjoys exploring and adventuring with her husband, 3 daughters, and dog. And we also have Mike Murnick, who's the VP Senior Physician Executive at Northern Light Blue Hill Hospital and has been a family practice doctor for 30 years. He's been ex-waivered MAT provider for 1 year and has practiced in Deer Lodge, Montana, Albuquerque, New Mexico, and Maine. Mike has lived in Blue Hill and practiced in Ellsworth and Blue Hill, Maine for 14 years. So we are delighted to have them both here to tell us all about how to integrate MAT into primary care, and I will turn it over to you.
Good morning. So I'm going to share my screen. Let me pull this PowerPoint up. And looks like we can see everything. So, let me get the PowerPoint. Sorry, I'm trying to get the slideshow to start. Okay. Hopefully everyone can see that. It doesn't look like it's going into PowerPoint mode exactly correctly, but maybe we just wing it from here. So I will say as a caveat, I have a little bit of a non-pandemic related head cold. So I'm a little, hopefully I will not sneeze in the course of this presentation. What we're going to talk about today is what happens after the X waiver. So what we know is that there are a lot of folks in primary care practices across the state who have really stepped up to the plate and done that training and gotten waivered, and then found themselves wondering what comes next. And their practices don't know what comes next. And I think what we'll want to talk about today really is that what we've found in our communities is that this is a team-based approach. It's a community-oriented approach that includes everyone in the practice and everyone in the treatment team, including the patients and families. So our objectives today are that you walk away feeling like you're clear on the tools and resources available to members of your team to empower your practice to provide care for patients with opioid use disorder. You'll be able to communicate and reinforce with all staff the importance of welcoming, empathetic, trauma-informed care for this patient population, and you'll understand the evidence behind the guidelines built into this workflow. And then I would just say, here we are. This is a map of Northern Light Health. Dr. Murnick and I both work for Northern Light Health in different areas of the state, but we cover, our footprint is pretty broad. I'm gonna pass off to Dr. Murnick. Oh, no, this is me as well, sorry. So let me talk a little bit about so we each belong to a community collaborative. And the one that I am participating in is in the Bangor area, led by Noah Nesson and held at PCHC. This is a subset of the Bangor area community leadership, community health leadership board. So I won't read all these organizations to you, but just so you have a sense of the participants, these are clinical leaders in all of these area organizations. The workflow, the handout that's going to be in the chat box, really came out of the work that was developed by all sorts of different folks from different organizations, looking at setting these standards across the community.
So hi, so this is Mike, and I work mostly in Hancock County and work with the Down East Substance Treatment Network, which started as just a group of concerned people meeting in a room at the City Hall in Ellsworth about 5-6 years ago on the first Monday of the month, getting together to brainstorm and try and figure out what can be done about the epidemic and how to improve access to care and care for our communities. And it has grown. The membership it's an open door membership, so people sort of come and go, but there's been a really strong core group that's been consistently involved. And out of this came a Down East Treatment Center, which is a hub and spoke model collaborative treatment center that is a place for stabilization and initiation of treatment that then feeds out to primary care spoke providers in the communities. And we created a handbook very much like the functional guidelines that you have a copy of or will have a copy of by the end of this. So the collaboration is really important. It's definitely teamwork, and the community involvement is great. If you don't have a network, you start meeting and talking to concerned people, and it can come together.
I think that truly too, what we found, it was interesting because Dr. Murnick and I were working in completely separate parallel processes in our collaboratives and really all came to the same conclusions. But I think what a lot of folks have seen across the state is that people who have been willing to start these programs without really clear guidelines once you're waivered for primary care prescribing, there were all sorts of things happening. So this sort of came out of kind of folks having some concern, seeing some overprescribing, some people being discharged from practice for behaviors that were really consistent with their presenting illness of opioid use disorder, being banned from a practice for months before being able to reapply, and things that we really felt were, considering the opioid epidemic and the public health situation, unsafe. So we wanted to make sure that we provided that support. None of this is prescriptive. I do want to say everybody has different resources in their community and their practices. These are sort of our best recommendations for doing what you can with what you have. You certainly can do more if you have more resources available, but we wanted to make sure that these guidelines didn't feel prohibitive to people.
And the evidence is out there. This was largely evidence-based, largely best practices. As I say, these two separate groups came up with guidelines and treatment algorithms and recommendations that are very much in line. So you don't have to start from scratch. You certainly can steal from other people. This is out there in the literature, and the models exist. But for us, it grew very organically out of that community relationship and collaboration. And the goal was to remove barriers. And a pretty obvious answer was we need to get more people providing MAT in primary care, which actually is a pretty big ask. I think most people know in their minds, or think in their minds, that it's the right thing to do. It's the evidence-based thing to do. It's the way it should work. We got to normalize this. But asking busy primary care docs to take that on in the setting of a big practice or a busy practice is actually a big ask. So people wanted a handbook, they wanted guidelines, they wanted support, they wanted to know that they had backup. And so that's what we wanted to work on. And that's where these guidelines largely came from. But there's also a lot of groundwork that has to happen with the staff and just the reception that people receive. There's a lot of fear about taking on this work in primary care, mostly due to old ideas and perspectives on working with this population. So you got to remove that stigma. One of the ways to reduce that stigma is to reframe our thinking about people with substance use disorder. And a great doorway into reframing that is to become aware of the relationship between trauma and the history of trauma, whether it's first childhood experiences, or just trauma throughout life, and substance use disorder. Hopefully people are familiar with the ACEs study. If not, look it up. We could happy to talk about it sometime. That was an amazing study that really opened the door to understanding the sources of a lot of common causes of early mortality in the world. Adverse childhood experiences are quite common. And what the study found was almost a dose response curve. To the more adverse childhood experiences you have, the more different kinds of adverse childhood experiences you have, the more it's repeated, the more risk you have of common causes of early death. And when it comes to substance use disorder, if you have an ACE score of 3 or more, three different adverse childhood experiences, you've got a 7 to 10 times risk of having substance use disorder. There's a huge connection there. And understanding that gives you a different way to approach these folks. View it as not a moral failing. It is a chronic disease. It's a maybe not very functional adaptation to getting through life and dealing with stress, but it is an adaptation to dealing with stress. And if you have these experiences, develop these medical issues, including substance use disorder, then you are much more likely to die younger and shorten your lifespan.
Mike, can I ask you, because I'm not sure which screen is showing, are you seeing the whole screen of the slide or just the partial?
I am seeing sort of the working form of this. So I've got all the slides on the left and the big slide in the middle.
Okay. It's showing up on my second screen. I don't know why that happened.
Ah, interesting. Maybe you're sharing the other screen. I'm
sharing the wrong screen. Okay, sorry. I'll try and fix that.
I think we can go to the next slide, I think. Yeah. So if we want to reduce the barriers to treatment, if we want to get providers to take this on, if we want to get clinics to take this on, we need to reduce, and as I say, is hugely important. The way people answer the phone when someone calls looking for treatment and care in this realm is really important. The way people are welcomed at the door, whether the reason there is called out to the entire waiting room, just the way people look at each other is all read very carefully. And it keeps patients from coming into clinics, and it keeps providers from wanting to welcome those patients into your clinics. And so we have to be aware of the language we use, be aware of the attitudes, and try and build a more therapeutic, trusting, open relationship so that people will come in and so we can take care of them. A really great evidence-based training or framework for doing this is trauma-informed care, which is well established throughout the literature. It's being trained in trauma-informed care improves provider burnout and provides patient engagement. It improves culture of caring. It improves so many things that we're all trying to, in diversity and inclusion. It improves so many things that we're all working on now. And what it is acknowledging that there's a really good chance that the person you're dealing with has a history of some traumatizing events in their past, and to just sort of respectfully and cautiously ask for permission to enter their personal space and enter their personal lives and develop that relationship. So it's a way of sort of setting the tone, taking the time and developing a trusting relationship so they can trust you. People that have been traumatized are frequently on guard and alert, hyper alert all the time, and looking for any little sign that things are going to go south and put up defenses. And you sort of have to cross that divide and gain their trust. And sitting down, taking the time, being respectful, can get you over that bridge. So trauma-informed care training is available from multiple sources. You can read on it. Jesse does trainings on it. It is a great way to kind of reduce the barriers and prime your clinic for taking on this population.
And I do think too that it's, speaking of we don't want to present any barriers. It's really important and helpful to get those trainings to orient folks, but it also is this simple. It's good patient care for all patients. Worst case scenario, you have somebody who doesn't have a trauma and they just think you're being incredibly thoughtful and careful with them. I know that I always appreciate it when I go into an unfamiliar healthcare setting and people introduce themselves and slow down and check to see if I have questions. This slide, we all hear a lot about the difficult patient. Now, people usually say high utilizers, meaning the patients that we see the most, who have the most unmet needs. They usually leave not feeling like we've helped them. We feel frustrated because we don't know how to help them, so they keep coming back. And the reality is these aren't difficult patients, right? These are human beings just like we are, but we don't know how to help them or how to work with them or communicate effectively. So it's sort of a shared responsibility. I had a primary care provider a while ago say that he had learned something important from me, and I was hoping it was some sort of big fancy thing that I had provided a training on. And he said, when I'm going in to see a patient and I anticipate a difficult conversation, and I know they're anticipating a difficult conversation, I stop and I take a deep, slow breath and I let it in and out, and then I walk in the room. And he said, it amazed me. The energy changed, the whole way the conversation changed. It really is that simple as, not trying to get ourselves to not walk in on guard. Patients, and we'll talk a little bit more about this, but patients who have had these histories of substance use disorder, of trauma, are not used to having honest, open, caring communications with healthcare providers. That has probably not been their experience historically. So just, I honestly, the more stuff that happens, the more time that goes by with everything that's happened this year, it all comes down to authentic connecting with other human beings. Just being a human being with another human being is really where the healing happens. Everything else is kind of a distraction. This is a whole, speaking of distraction, this is a whole page about SBIRT. Many of you are probably familiar with this. Screening, brief intervention, referral to treatment. It's really the workflow of all of primary care. And as Dr. Murnick said, primary care folks are very, very busy. They have patient after patient with every possible presentation under the sun. and everything from very mild to, life and death critical turns in their day. So incorporating all of this work into that workflow is incredibly important. And what's recommended by the American Association of Family Physicians is an opening annual question for all patients in primary care practices. How many times in the past year have you used an illegal drug or used a prescription medication for non-medical reasons? And they recommend clarifying, for instance, because of the experience or feeling it caused. And that just sort of opens the door. Now, there are longer screening tools, there's more intensive screening tools, but most of us know that those annual screenings in primary care, there's a lot of things that people are being screened for. So we really want to keep things as brief as possible because there's a lot of people to whom this won't apply, and we don't want to bog down their visit with something unrelated to their clinical presentation. I will say, often patients will say no, not at all the first time they get this. Maybe the second time, maybe even the third time, but you are establishing for these patients that this is part of their health care. This is okay to talk about here. You're not intimidated by it. You are open to this conversation. This is the right place to come. This is an access point when you're ready. That is really important, and I think it does pay off.
If I could jump in there
Thinking
while you're
about, oh
catching
yeah,
your breath.
please.
Um, yeah, the SBIRT's a great form. I think there are great efforts to make it fairly universal, and I fully support those efforts. First, a fair number of providers are resistant to screening for something if they don't feel they have the resources to refer to. They say, don't screen for something you can't do anything about. They're worried that they'll just open a Pandora's box and they'll be stuck, and they're going to be stuck in the room for an hour trying to solve something they can't solve on their own. There are more and more resources becoming available, and you can be. I think that that as a reason not to screen is with us for quite some time of opiate use disorder. We know we need to deal with it. And you won't know unless you ask these questions. There are people in your practices that need help, that maybe are even already on MAT and you don't know it until you start asking these questions. And certainly people are using opiates and substances that you don't know about unless you ask these questions. And you can't get help, you can't open the door to that treatment unless you ask. So we have to start screening for this stuff.
It also destigmatizes substance use disorders, right? Us being willing to ask, I mean, we're asking this question just as we would ask about blood pressure, just as we would ask when we ask about tobacco use. And as Dr. Murdoch said, it's a chronic health condition, and this is a primary care practice. This is where you should be able to get help with your chronic health conditions. This is a slide about diagnosis. All of these slides that really get into the weeds are in the workbook that the handout that is available to you. So I'm not going to go through these in excruciating detail, but I did want to pull them up just to really emphasize that it is a team effort. So, and what we've sort of dug into here is who in your practice might be able to support the work of the patient and the provider in making this happen. It's not all on the person who gets the X waiver. There's a whole bunch of folks in your practice who can participate in this process. And we do mention here the MAT agreement. If a patient is found to be a good candidate for MAT in the practice, this is a really important step. And this is not just a commitment for the patient, this is a commitment from the provider. So really, I mean, ideally, this is the provider who's going to be managing the medication and the patient are having a conversation about what this really means. And what I talk about with patients is honesty, that no one's expecting that you're going to be perfect. No, certainly don't expect that I'm going to be perfect, but we need to be honest with each other if we're going to do this, because we're here for you, not for me. So there really is no motivation to not be straightforward.
Setting really clear expectations is important, and so a standard agreement that goes through what each side can expect is just a great way to make sure that's clear and in writing, and you can give people copies, and it's in the record. You can go back to it and revisit it if you need to. It is an important thing to set clear expectations.
This is a partnership between the practice and the patient, and it's important for us to be accountable to our part, so patients know what to expect. We typically screen for or we standardize screening for anxiety, post-traumatic stress disorder. All of these tools, the tools that we recommend that we use that are evidence-based and available without cost, those are all in the workbook that's attached. But also including intimate partner violence screening. There's a lot of folks who are in the relationships affected by intimate partner violence here, and as many of you know, this is a pretty prevalent problem in Maine. And I think we're shifting back over to you, Dr. Murdoch.
Yes, I think you're right. We are. So I think the main thing, again, we have the guidelines, the outlines for what to do, but what you're trying to establish is a trusting relationship. You're trying to establish that rapport. So being open and honest, meeting people where they are is really important. And then figuring out what level of care is appropriate. So there's all the screenings for other mental health issues that Jesse mentioned. A lot of these folks have not been coming to the doc for a long time because they've been busy trying to keep up with their habit. Others, as I say, you'll be surprised, they're already in your practice and you just didn't know it. But when someone's coming in and started treatment, screening for other medical issues that might be brewing underneath and hidden and neglected is definitely an important part of the intake. And then an informed consent about the treatment with the medications where appropriate. Drug screening is an important part of the work, and one that's been maybe misinterpreted or misused in the past, or that ideas about it are changing as we go more towards a harm reduction perspective on all of this treatment. Some old hard and fast ideas about what to do with a drug screen are falling by the wayside. They really are just used to support and confirm what you're working with in your trusting relationship and trying to be honest with everybody. So a common recommendation say, so what do we expect to see in your urine today before you get the urine? It's not a gotcha. You're not being a policeman. You're not being a detective. It's really just a tool that the two of you are working together with to encourage sticking with the program. It's not a reason to kick somebody out of the program necessarily. It's a reason to start the conversation and say, hey, that's in there. How did that happen, and how can we work on getting you sort of back onto the program? Counseling is a hugely important part of this, and the evidence suggests that the best outcomes from being involved in counseling and the medication part of the treatment. Our guidelines and Bangor's guidelines, strongly recommend it and support it and have lots of ideas. We have counselors in our clinics that we use, LCSWs. Acadia has counselors. There's lots of private counselors. There's groups around. You want to have you want to do a release of information so you can get notes if they exist. So you can share collaboratively, so a counselor can say, hey, this is what they're talking about. It might impact, especially it might impact your prescribing. And likewise, you might say, hey, we're going through a rough patch here. You might want to step up your counseling and go more often for a while, and communicating back and forth with the counselor and the prescriber and the providers can be really important. That said, we don't want to say this is an absolute requirement that you do this. Travel is hard, work schedules are hard, access to counseling is sometimes not always widely available. So we don't want to say this is an absolute requirement. When we set up our guidelines in Hancock County, the Downey's Treatment Center, we said, no, this is at best evidence-based practice. We're going to require this. We're going to be really sticklers about this. It doesn't work, and we've backed away from that. Most people enjoy the counseling if they can do it, but it's not a requirement to participate and keep going in the program. We don't want to make it black and white. You got to meet people where they are and try and do the best you can.
I just want to take a moment to talk about engaged empathy. Um, just because, again, I think the authenticity and that connectivity is really at the core of this, of all of this. You know, we know that this is not work where you can just kind of show up and do your tasky work and be done. It really is tiring because you really do want to make those connections, and it's also more meaningful to you as a provider, to the patient, to the families that folks are engaged. So, you know, just focusing on the patient, sharing an experience, 5-10 minutes, you know, you can kind of guide people to talk just a little bit about their own experience, so they feel like they have an opportunity to share their story. And we do know that even though you can tell people what to do, and we all know this from smoking cessation and, you know, diabetes management and all of these other educational, you know, all the wisdom we try to pass on and we try to accept as human beings, is that just information is not enough. There has to be that emotional component, that engagement, that connection. There has to be buy-in. So people can know, and most people who are actively using know that there are places that they can get help, but it's really that kind of that buy-in and connection that is going to sort of maybe open that door for them.
Yeah, so this one's mine. So yeah, the therapeutic relationship is hugely important. And back to that written agreement and clear expectations. You really want to be clear where the guardrails are, and so maintaining those expectations with that written agreement is really important, both for them and for us, to be clear about what we expect and what's expected of us. Hear time and time again from people that have been doing it longer than I have, and in my practice too, people that are successfully farther along in their recovery look back and are hugely thankful that they were clearly held accountable for their behaviors. That was a really important part. They were happy that the drug screens were there. They were happy that we did what we said. And if they slipped up, we recommended more counseling and started seeing them more often and giving them smaller supplies for a while until they built back up to longer periods. That accountability, they were hugely happy that it was there, and they attributed a big part of their recovery to it having been there. And we've had people move into our treatment programs from less tightly structured programs and say, like, this is what I needed. I needed a little bit more structure. I need a little bit more accountability, and that's why I'm here. And that's what we're thankful for. So setting those established rules is really important. And this is part of why it's important to have established rules and guidelines to go by. People that are dealing with this chronic relapsing illness that affects your judgment, that affects your executive function, and has changed the focus of your life from doing all the things you should be doing to how are you going to maintain your supply and keep feeding your habit, are used to or fall into some deceitful behaviors. They're lying to themselves, they're lying to their family, they're lying to their boss. It's just part of the disease. So you can expect, particularly early on, before people gain perspective and come back out, some deceitful behaviors, and to be tested out as a new provider, to be asked for more. Couldn't we do more? Because that's how they used to get what they needed from docs, was, well, yeah, I'm in more pain, I think I need more, it's running out, or it got stolen, can we get some more from the provider? And if you're really clear up front, this is the plan, we're going to stick at this dose or go down, but we're not going up unless there's some real extenuating circumstance. If you're clear, then it's all up front, and you can go back to that agreement and point to it and say, this is what we planned, because you can expect relapses, you can expect slip ups. It's very common early on, but it can happen anytime, particularly during stressful periods in life, anticipated or unanticipated. It's the old coping mechanism was to use the substance, and we're breaking away from that, but it's not uncommon to hit a stressful patch, or something happens, or someone they knew died or overdosed, something happens, to go back and slip up. So you expect that. You can follow the plan. You keep working with them. You don't kick them out of the program. You're much better off continue to work with somebody and keeping them in treatment than slamming a door. We want open doors and no wrong doors, not shutting doors. So yeah, so when that happens, we expect it. We know what's going to happen. Having that relationship really helps, and being honest. Say, hey, look, here we are. We knew we'd be here someday. This is what we're going to do. Ask them, how did this happen? Why is this in your talk screen this time? Okay, how can we work with that? Should we do more counseling? Should we see you more frequently? Should we give you a smaller amount so you're not having to manage that supply for so long, if that's a temptation to have all that there? Trying to avoid that judgment and understand that it's a disease. It's not a moral failing. It is what we're dealing with, and trying to sort of help them train themselves out of. Don't be judgmental. You'll hear stories that may be somewhat surprising to you, but this is these people's lives, and we need to understand them, and then figure out how to best support the patient's recovery.
I think people are really, people are really surprised when you respond with support. And I think that's one of the pieces that's really critical to that relationship is that's when, that's when people with use disorders are often used to be having people that they care about, shut that door, and understandably so. But this is a different kind of relationship, because our goal is to support them on their recovery path, understanding that sometimes it's going to, diverge and have stops and starts. So that this is an opportunity to really show that partnership. And kind of back to the language and destigmatizing we talked about earlier, I think a lot of people are aware of this now, but really just making sure that the whole practice understands that we do not talk about dirty urines. That's not the way that you speak about somebody who has a positive urine screen. That's not what you say when somebody has, a UTI. And this is it's evidence that there's an acute episode of a chronic illness. And so we should really be using those terms. So again, we've talked about this a lot. Misusing and diverting are symptoms of the disorder. We want patients to come back early in the when we became aware, when we started following guidelines, and patients were being tapered, and we became aware of a lot of patients who had been getting prescriptions through the primary care practices who had been diverting or misusing substances. There was a lot of shock, I think, and on the part of the practice and the prescribers. And we as a people were hurt as prescribers, because many of these patients we had decades-long relationships with. And I saw some, primary care providers responding out of that emotion, and, sending patients letters saying, you're not in this practice anymore. You lied. You've been selling a substance that's not safe. I can't prescribe to you anymore. And that was when we really started to realize how much support was needed, not just for the patients, but for the practice and the providers and all the team members in the practice, to understand the nature of this illness. And that if you kick somebody out of your practice, where do you think they're going? They don't disappear. They don't go to a magical rehab. They're in the community that you live in, still struggling with an active use disorder, and now they have lost a touch point in the healthcare system that might have been able to start their path to recovery. So, you know, the accountability piece is important, the agreement is important, but part of all of that is that we are knowing that it will be hard in moments. We're walking through this with them. Um, and most patients with an opioid use disorder have a co-occurring mental illness, such as depression, anxiety. ADHD has a really strong substance use co-occurrence, as does bipolar disorder. Lots of folks who have been using substances since they were very young may have a bipolar disorder that's never been diagnosed because the symptoms are masked by their substance use. So screening and connection with treatment is important. This is some really direct screening for phone staff. And again, we started working on this scripting on the fly in the beginning of all of these tapers happening, but then, you know, later refined and adapted it. What we found is that the folks who answer the phone, although they don't have a clinical background, they don't have a clinical degree, many of the people were asking not just to, we're involving them in the clinical process. So if they are scheduling appointments for patients or rescheduling appointments or greeting patients at the door or asking them to come in for an unexpected medical visit, we need to equip them with tools that they need to respond so that they don't escalate the patients and then they themselves don't get escalated. I have ongoing conversations with staff members in the practices about, you know, we all have at this point, there's very few of us that haven't been somehow affected by a substance use disorder, whether it's a family member, a close person in our lives, we ourselves. So we all carry our own, you know, baggage about this stuff, regardless of what our relationship to it is. And we really need support. So if you just look at the responses here, you know, what will happen? What will happen if I don't come in? Well, let your provider know. Please understand they may talk to you about alternative treatment at your next appointment. If the patient becomes agitated, you could just respond, I understand that you're upset. You know, I'll let your provider know. Is there anything in particular you want me to tell them? So helping, just providing some support for our folks to stay calm, be welcoming, really that no wrong door goes all the way through the recovery path. It's making sure that door stays open, not just open initially, but stays open. We're going to talk to people respectfully, like we would want to be spoken to regardless of where they are at in their illness. And I will say, as a behavioral health provider in a medical practice, I do often put myself out there for anyone who wants to debrief a difficult conversation in the practice or touch base. And people often do, because it's hard to stay calm and be neutral and professional when somebody is calling you names or yelling at you. That's not okay. So, and of course, to some extent, when things go in that direction, then we need to round back to the patient. And then it's the provider talking to the patient again about accountability and the behaviors that are okay and not okay in the practice. And because of the effect that it has on team members. Again, scripting for medical assistants play a huge role in all of this. Medical assistants are the unsung heroes of primary care, frankly. They do a tremendous amount of complex clinical work. It's just getting more complicated all the time. So the more we support them, provide them educational and ongoing support opportunities, the better things will be for these folks, but also for our patients and the communities and families we serve. And then, oh, sorry, go right ahead.
Quite all right. Quite all right. Yeah, so we've talked a lot about, you know, hanging on to people, don't kick them out, keep them in your practice. But that doesn't mean that you have to handle absolutely everything. There are times when it's entirely appropriate and people need a higher level of care than what you can provide in the primary care office or even some treatment centers. As Jesse said, there's a lot of co-occurring significant mental illness and behavioral health problems, some of which has been sort of self-medicated for years, that becomes unmasked or just needs more help than what you might be able to provide in a primary care office. Or if you're just not getting there, I mean, you're following the expected treatments, but the use and misuse of non-prescribed meds or other meds just keeps happening despite your best efforts to follow the guidelines. multiple unexpected drug screens that you can't deal with the response of, hey, it's a relapse, let's deal with it. Or just absolutely not following the expectations that you both signed an agreement that you were going to follow, that puts people at risk, themselves or others. Those are all reasons to ask for help and find a higher level of care and get to an inpatient treatment center, an intensive outpatient treatment, some other level of care. So you'll hear it in your waiver training. It's in the handbooks. You got to find what is your out if you find yourself in over your head with a certain patient or case. So you should think about that as you plan to take this on, and know what your route is, know what your referral patterns are.
And the good news is that now there's a lot of these services are available virtually. So there are even IOP programs, intensive outpatient programs, and so knowing how that, because of the public health situation right now, a lot of folks can't get out. There are a lot of pathways to higher levels of care that were not available previously.
And then, we're talking about MAT, we're mostly talking about Suboxone. And tapering is another thing that has evolved. The thoughts about tapering has evolved over time. The old idea was, I don't know, kind of like nicotine patches or something. You do it short term, you taper off, you're done. That view is gone. And some people need to be on this for a long, long time, or maybe forever. It's always an effort to taper down and get to the lowest amount that's needed. Some people get down to amounts that you think can't be really clinically significant, but they're psychologically significant. I've heard of I did a training down in the Philadelphia area, and they talked about a professional, a surgeon who was on this treatment, who was taking a 16th of a film, of the smallest film, every day, which is a tiny amount, but continued forever, and that kept them on the path, kept them in their recovery, and was helpful. And so that's what they did. So tapering is, there are sort of rules of thumb to try to get to, but not everybody has to taper, and not everybody has to get off. The main thing is we're trying to keep people in recovery and get on with their lives.
So we've talked a lot about partnerships, about the community partnerships that we've developed. I think one of the more amazing things that I've seen come out of all of these really difficult public health epidemics and pandemics and all of the stuff we've been dealing with is these community collaborations between healthcare organizations, peer recovery groups, which we didn't even talk about today, but they can play a huge and important role in helping people find their own unique recovery path. So we have opportunities to model compassionate, inclusive, coordinated care for all patients, education and advocacy for policies and workflows. I think really those of us who are doing this work, who are invested in helping this patient population, if you have an opportunity to participate in an ongoing committee or group in your organization in which you can be a voice at the table advocating for patient-centered, destigmatizing language and policies, I think that's an incredibly important way to help a whole lot of people. And improving communication. And we talked a lot about mutual accountability. And then finally, resilience and empathetic engagement for every healthcare employee in every role. And I think we both feel so strongly about that. And I can't emphasize that enough, we need to really place as much value on the person who is greeting patients as they walk in the door as we do in the medical provider, because all of those folks are the team that are going to create an environment in which people can feel welcome and get well.
Yeah, I completely agree. I think it's a really important framework, and maybe the most important part of it. We in Hancock County with the Down East Treatment Center handbook that is very much like the handbook that you have. That's what we wanted. We needed the algorithms. We wanted it all there. We wanted a reference we could pull off the shelf. It actually very rarely gets used. But the training of the staff to make everybody welcoming and everybody understand this and take this on was probably the biggest part of the work. So laying that groundwork, creating that culture, a culture of caring, that we will take these people on, or acknowledge those that are already in our presence and already in our practices, and help them with stay in recovery. Is probably the biggest part of the preparation. Other barriers we may get to in the questions, which I think we're up to. It's still this work still doesn't pay very well, which is another reason that a lot of clinics and providers don't take it on. But the payment is getting better, so that's other things to sort of lobby for, is making sure that you get paid for this work. But building that team and doing the preparation, it is very doable in primary care, because you don't have to do it all, and it's a team effort.
Great. Thank you so much. Lots of really good information there. Have a couple questions. The first one was around one of the barriers people often say, and Jesse, you mentioned this a little bit, but particularly in rural populations, hard buy-in within primary care practices because of the feeling that there aren't resources around if there is a need for that higher level of care. Can you talk about sort of what that looks like, and in particular, you know, the telehealth piece that you already mentioned?
Yeah, I think that we have actually a whole worksheet, workbook that we can share of virtual resources. There's so many of these of folks that were all in bricks and mortar. I mean, I think a lot of the barriers that we had created for ourselves in healthcare, right, sort of fell away when the pandemic happened, and we had to be creative fast. So, especially in rural communities, patients should have ongoing access to virtual treatment. I on my team have a couple psychiatric nurse practitioners who live in Indiana or Arizona who practice telehealth full time and manage MAT in rural Maine communities. So the barriers are really very few. And I know I would be happy to help anyone who needs to connect with some referral with an easy or at least straightforward workflow for accessing higher levels of care when needed, because you do need to have that in your back pocket. There will be times when, even if only to reach out as a provider and get some ongoing support with and present patients.
That's helpful. There's someone in the chat that would like to have that information, so hopefully we'll make that available. The next question is there any place in your practice where you advocate the use of recovery capital measurement instruments such as the BRAC-10?
That's actually one I'm not familiar with. Are you, Jeff?
Me either.
No? Okay.
Nope.
I am not, as this is a question from the box, so I'm not as familiar with that either. So we'll move on to the next one.
Happy to learn about it.
Yeah, for sure.
There might be a place for it. I don't know.
I've heard of recovery capital, but I don't know that one. So one of the other questions is challenges or solutions in dealing with, as the complexity of the substance use disorder problems, you know, get broader, particularly as we see with stimulants. Any particular suggestions of how you modify things or how you address that within the primary care setting, I think would be helpful.
I'll just chime in to say, much as we try to come up with algorithms for that sort of thing, you really can't, because human beings are all different. I mean, it is true that having stimulants in your system at the same time that you are using opioids is dangerous, and particularly if you're involved in illegal, you know, substance, you know, purchasing or diverting. So that would need to be a very careful conversation with the patient to determine whether you can safely continue prescribing in a primary care setting. However, also patients who have ADHD who might be taking stimulants, if they are off stimulants, they're actually at higher risk of high-risk behaviors, impulsivity, and their substance use disorder may be destabilized. So unfortunately, this is sort of why that's a good example of where a team is really needed. It's helpful to have a psychiatric provider in the mix, someone to bounce things off of so that you can work together and make sure you're on the same page with the patient to care for them safely.
Yeah, and you want to be careful of absolutes. There are, you know, some substances that used with Suboxone, used with opiates, are lethally dangerous. So benzodiazepines are, you know, hard, avoid those. Alcohol is very dangerous mixed with it. The stimulants, dangerous, not great, but not necessarily immediately lethal. So you would work with that. You'd certainly talk about it and try and get some help and try and get rid of it. But again, it's not going to lead to an absolute black-white response, most likely. Likewise, marijuana. I mean, I think harm reduction perspective that is growing as we, in many ways, fail to make a dent in this epidemic, has changed a lot of black and white answers into gray answers and maybes, and well, we'll work with that.
Great answer. Any thoughts on sort of specific processes that you employ when you have difficulty getting buy-in across the practice when you're trying to get a primary care practice to go online providing MAT? Like, how do you start with that? Is it stigma education? Is it something else? And what does that look like?
So I have something called, basically it's a survey and then a training. So what I ask folks to do when I go to a practice and we're introducing this work is to complete an anonymous survey where they identify a patient population or a few that they find most challenging to provide excellent care to. So not just to work with, but to provide excellent care to. And people will often say, patients with substance use disorders, sometimes they will say things surprising, like people with trauma. They just don't know how to interact. And when you have a sense of what the sensitivity is in the practice, I think it's easier then to tailor your training to that practice. Every practice and community is different. Everybody's going to have kind of different points that they need strengthened, but I think the most important thing is to include the whole practice from the beginning. So before you open the doors to the patients, before the prescribing starts happening, we have to provide this education in a way that really isn't just talking at people, but includes them, gives them some space to put their worries on the table so we can talk about them. And we can talk about how, one thing I'll just say quickly that I find really effective in those conversations is to talk about how a few years ago on Facebook, there was a meme that was up, or a picture that somebody had taken that showed a couple that had overdosed and died in the front seat of their car. And I'm just now able to talk about this picture without crying. And these two very small children in the back seat who are awake and playing. And it was all over my Facebook page when that happened. It was everywhere. And a provider that I knew posted it and wrote, pieces of underneath it. And I thought about that so much because I thought about those kids and what were the parents' lives like when they were kids? It's like people age out of empathy. If we had seen them when they were kids and they were in their home environment struggling with whatever their struggles were, we would want to help them. We would want to wrap our arms around them and find them a safer place to be. But it's like kids get to a certain age and then we're done. Like, no, now you should know better. Now you're 17. When you were 16, you were adorable. Now you're 17 and you should just know better and we're not going to help you. So I think it's valuable for people to think about that. We're just human beings, and nobody wants their life to go off the rails, but sometimes it does, and sometimes we all need help. And I do think that everyone could kind of identify with that to some degree. Really humanizing humans is what it comes down to, because there's so much stigma and you really have to dig through it.
Yeah, I agree. I mean, I think every clinic is a community. And the first part of a community assessment is to ask what the community wants and needs. So different clinics may have different needs. And I think that the trauma-informed care training is hugely important. Found it very widely needed and asked for. But that's not what our people asked for initially. They wanted the guidelines. They wanted the handbook. They wanted the outlines. So that's what we worked on first, and we did that. And it still didn't budge everybody. So we kept working. And I think that breaking down this stigma is really a key part, but it's going to be different for every clinic. So I think you got to ask, have that open discussion with everybody, from the front desk back to the providers and the people that answer the phones and the managers and absolutely everybody, and say, what do we need to take this on? Because it's an important thing. We got to take it on.
I think that's a perfect way to end it. Beautiful explanations and descriptions. I really like the positive reframing of serve well as opposed to work with, and really think about the stigma and the trauma-informed care, and just the open-ended questions. I think letting people tell their story, such a critical piece. So thanks to you both so much for coming and for presenting. It was a wonderful talk. And thanks to all those who are on the Zoom. And again, please join us the first Friday of the month, next month, December 4th, for a talk on prevention. Thanks for coming,
everyone. Thanks for the opportunity. Thank you.